housekeeping things I need to do. I need to recognize we've had two gracious industry supporters. We have a number of industry supporters, and you'll see in the packet you can recognize those folks. But two of them have stepped forward and actually sponsored this particular meeting, and we're very grateful for that. Pays for the orange juice and other things. More than that, but thank you. So it's Fresenius Kabi and Pharmedian. Two very important groups involved in delivering drugs to us. And they're very interested to learn from us, and we're interested to learn from them also. So I'd like to recognize them. In addition, I'd like to recognize, I don't know if Stacy, she must still be outside, but if you see a young woman sitting at the desk out there, blonde-haired, black sweater, that's Stacy Maxwell. She's our administrator, so if you have any questions, anything you need assistance with, please go to Stacy. She can help you with any of that. And then this morning, we have two breaks this morning. We have a quick 15-minute break because I know a lot of folks drank a lot of coffee out here. So I think from 9 to 9:15, we'll take a quick break. And then later on, we have I don't know if it's a coffee break, snack break, something a little later on for half an hour. Then we'll have lunch. Then we have one break in the afternoon. Pretty sure we have cookies, but I'm not sure about the milk. So again, if you were able to get to reception last night, really appreciated you having the opportunity to do that. We're going to do it again tonight. The Royal Palms is a spectacular place to do this because it's very small and self-contained. If you want to go out to eat, you either have to eat here or you got to go somewhere. So what we do, we thought we'd just have another reception tonight, different menu. So if you ate last night, you can eat again tonight and have a different menu. So we're just trying to keep it easy for everybody. As we go through the agenda, I've asked my co-host, Dave Goodell over here. Dave, will stand up so you can see who you are. And so Dave, I'll introduce him when we start doing sessions. And then Tim Vanderveen over here are the co-hosts. And they're really the folks that put this program together. These folks are very knowledgeable in this field. I'm not so knowledgeable, but I can help put it together. And they were terrific. And they're going to keep the introduction of all the speakers very short and simple. Because if you go to the APSF website, apsf.org, and you go to the conference, in there it's got the whole schedule. But for each speaker, it's got their photo, it's got a bio sketch about them. So you can read a lot of information about all of our great speakers. So we're just going to keep the introductions really short to keep things moving. My apologies to the speakers for doing that, but I think it's a really nice way to do it. You'll be amazed at the accomplishments and the responsibilities of our speakers. They're pretty terrific. So within a week or two, we'll summarize what we do, the recommendations, and also we are going to have summaries of each of the presentations. Our presenters have kindly provided us with about a paragraph or some bullet points of the key takeout points from each one of their talks. Those will be up on the website. So we'll have that. We'll also have links to any articles they identified or references they've identified that are very useful to this. So you're going to get a nice bibliography out of this, a reference list. You're going to have key takeaway points. So I won't necessarily claim it'll be up next week because it's been a long summer and my wife and I are going to Yellowstone after this. So I'm not going to be here next week. But shortly thereafter, by the end of the month, we'll have that up. Right, Mike and Arnie, our website gurus? Oh, yeah. Okay. So I would like to just end my part of this by basically thanking each of you for being here. You guys are terrific. I actually wanted to tell you, this is a noble cause, and you guys are noble people for taking the time to come do this, and we are very, very grateful. So what I'd like to do is introduce Jeff Feldman. Dr. Jeff Feldman is the head of our Committee on Technology, and Jeff also is an extraordinary anesthesiologist at Children's Hospital in Philadelphia, and he's going to introduce some award winners. We had an award related to this.
Good morning. It's a pleasure to be here this morning. I'd like to, on behalf of the APSF, announce the winners of the Medication Safety Award. This program, let's have to figure out how to change slides here. Let's see. Nope, that didn't do it. Did you figure this out yet?
Nope. Can you help?
The arrows aren't working. Anyway, there we go. Thank you. Next slide. That's perfect. So for those of you who may not be aware, this award was announced back in March in preparation for this conference. Came out of the Committee on Technology. And basically the award criteria were announced in March and based on trying to identify best practices that had implemented some versions of the STPC paradigm, standardization, technology, pharmacy, and culture, that APSF had identified several years ago in conference on the same topic. We specifically wanted ongoing programs, not just ideas or technology that looked good but had not been implemented. So we asked for a description of the objectives of the practice, the clinical workflow that was designed to support the practice. Integration with the electronic health record was important. The duration of time the practice has been in use, approximate number of patients impacted, and methods used to evaluate effectiveness. And we were very pleased to get 7 submissions from around the country. Of those, 3 were selected that we felt met the criteria sufficiently to merit recognition. And so next slide, please. In the honorable mention category, the project was the Codonic Safe Label System, utilizing technology to increase medication labeling compliance and charge capture while maintaining user acceptability in pediatric operating rooms. And is Dr. Thomas here this morning? I've had a chance to connect with him, but... oh, okay. Pat Guffey. Okay, so we have Dr. Guffey here if you want to come up. And we won't take time today to describe the details of these submissions with the exception of the first place winner who will give a short presentation. But that information will be published in the APSF newsletter. All the submissions will also be on the website, so you'll be able to review that over the next couple of months. But Dr. Guffey, I wanted to shake your hand and thank you very much. There is a plaque. There is a plaque that was not available for this conference, but you will be, and your colleagues will be receiving it. And
James sends his regrets. His wife was 37 weeks pregnant. I was his mentor on the project, so he asked me to come down here. But I can't thank the APSF enough for the opportunity to recognize the great work that James has done at Children's Colorado. So thank you again.
Thank you so much for the great work. So the next slide, please. So in the second place category, the project name is Michigan Medicine Anesthesia Medication Safety Initiatives, and Dr. Deborah Wagner is here. Deborah, yeah, you want to come on up? Come on up to the podium here. Thank you. Just want to thank Deborah for all the great work. I think their submission was really notable for the cultural changes that they really emphasized and developed in their organization. I would encourage you all to take a look at their submission. And again, you'll be receiving a plaque in the near future.
Thanks, Jeff.
Yeah.
I just want to call out one thing for the culture at Michigan I think is really important to know is that Dr. Kevin Tremper, the chair of the department, has always been a firm supporter of an alliance between pharmacy and multidisciplinary work. And so we've really taken that to another level in the last few years. To really address medication safety issues. So thanks again.
Yeah,
it's
thanks for the great work.
Thanks.
Yeah, really appreciate it. And we don't have a drum roll, but I will take the next slide. And in first place, the title of the project was University of Washington Medical Center Anesthesia Drug Safety Bundle. And Andrew Bowdle is here to receive that award. Andy, are you okay? You want to come on up? And Andy has a short presentation. What really I think impressed us a lot about this work is that it goes back to actually to 2002. So these guys have really been at this for quite some time with data collection and improved processes, and I think we can all learn a lot from what they've done. So I'm going to hand the podium over to Andy so he can give you a little more details. Thanks so much.
Thanks very much, Jeff. Good morning. Thank you very much for this recognition. We have indeed been this drug administration safety and trying to find ways to reduce drug administration errors in our practice has been an obsession with us going back to about 2002. looking at the slides backwards now. Can we go back to the beginning? Can you guys do that? So there are a ton of people who did this with me, and there isn't enough time to acknowledge all of them. I want to acknowledge a couple. Surgeon Yelisich, who's an anesthesiologist, who's a cardiac anesthesiologist and a clinical partner of mine, as well as a research partner, is here, was very instrumental in this. And also Ballinaire. Ballinaire is a PhD bioengineer who does all kinds of miraculous things with our electronic medical record and with data collection, and we couldn't have done any of this stuff without him. And then I want to acknowledge two New Zealanders, which I'm sure at least some of you know. Is there anyone here from New Zealand? No? So Alan Mary is an anesthesiologist in Auckland, and Craig Webster is a PhD who's really an expert on human factors. And those two guys really inspired us before 2002 to get into this field and do the work. And I think their work in this field was really crucial. And they've collaborated with us since then. They don't collaborate with us on a daily basis. They're too far away, but we interact with them pretty frequently. Can you do the next slide? This thing is not really working. So over the time we developed this bundle, it's in the time I have to talk to you this morning, it's really not, okay. It's really not possible to go into all the details of this. But all of these things working together have allowed us to put a significant dent in the incidence of drug administration errors, which we've been measuring on a continuous basis. And I think you'll be able to see more details about this, about the bundle and how it works in publications and in the newsletter and so on. Can I have the next slide? So these are the peer-reviewed publications about what we're doing that are currently available. There's two that are published. There's one that's accepted for publication and one that's under review. So if anybody's interested, thought I'd just give you a quick look at that. So I thought about, what I could say in a brief amount of time that would kind of reflect some of our current thinking or where we think we're going with some of this. And one of the things that I've been spending a lot of time thinking about and working on in the past year is the intersection of drug administration and infectious disease, which I think we've mostly been preoccupied with mechanical aspects of drug administration, not picking up the wrong syringe, not picking up the wrong vial, and so on. But it's become increasingly apparent that without intending to do so, we're often injecting pathogenic bacteria into patients when we give them anesthetic drugs. So that's just something I wanted to bring up this morning. Next slide. So I think that despite an abundant amount of evidence that open stopcocks, as shown on the left there, are harbingers of bacterial infection, they're still in wide use in anesthesia practice. And several years ago, we made a big push to close all our stopcocks and then also cover the claves on the stopcocks with isopropyl alcohol caps and keep those caps continuously in place. So the surface of those claves where you attach the syringe and inject the drugs is always sterile when it's used, as long as those caps are in place. And we've had pretty good success in our practice getting people to use these, and this is our standard approach now to stopcocks. Next slide. Another thing about keeping bacteria out of anesthesia drugs that I discovered fairly recently that I think is interesting and that I think many people don't understand. So you look at that vial on the left, it's a typical vial of an anesthetic drug, like our carts are full of these. There's a plastic cap on the top. Many people, if not most anesthesia providers, believe that the underneath that cap is sterile. So if you pop that cap off, that rubber stopper that you're going to stick a needle through to draw that drug through is sterile. And it's not. It wasn't designed to be sterile. It isn't manufactured in a way that will ensure its sterility. And if you're a pharmacist, you know this, and you take and scrub the top of that vial, that rubber stopper, with alcohol, illustrated there on the right, to clean it before you stick a needle in it to draw up a drug. Alan Mary's group in Auckland recently published this paper cited there in Anesthesiology, where they showed that when you have anesthesia providers draw up drugs into syringes from vials in their usual way, whatever their usual standard practice is, they've shown that there's significant pathogenic bacteria in those syringes. They're then being injected into patients. Now, how much of it's due to not cleaning the vial tops, I have no idea. The bacteria could be coming from a variety of places. But anyway, clearly, there needs to be more attention paid to disease prevention in anesthesia drug administration, along with the things we've been doing for years about trying to avoid administering the wrong drug and so on. I took this picture yesterday. I just went up to my satellite pharmacy window. I said, Dolly, can you please give me a whole bunch of drugs? So I took a bunch of drugs, and I could do this next week, and I could ask her for the same drugs, but it wouldn't look the same, right? Because we're constantly dealing with drug shortages, drugs coming from a different vendor because one vendor's out and they're coming from somebody else. So there's syringes here from 2 different commercial outfits that pre-fill syringes. There's a couple of syringes that were pre-filled by our pharmacy in our clean room there. There's a bunch of vials. And so, I think back to when I was a young man doing anesthesia, and you came in every day, day after day after day, month after month, year after year, and the vials were all the same. I mean, every once in a while, maybe the label color would change or something. That was like a big deal. Now, every week, this assortment looks different. And I think, if anything, that's just added to our challenge in trying to help people avoid anesthesia drug administration errors. And I think we need to somehow try to figure out how to address this. Thank you very much.
Thank you very much, Andy. Okay, it's always good to have a story. And we have a great story and a great storyteller today. May Pien-Smith, where are you, May? May is an anesthesiologist at MGH. She's also the head of the quality and safety in the department, and is just an all-around terrific person. So, May, thank you very much.
Thank you. Thank you, Mark. Really, what an upper to be here today in a room filled with kindred spirits who care so much about improving patient safety. And I'm kind of feeling like it's pretty special to imagine the magic that's going to happen when we apply our heads and hearts together to solving these problems together in the next 2 days. So many of you, as you just heard, I'm an OB anesthesiologist at MGH. I've been there 25 years. And I like to show this favorite picture of mine, which shows the Bullfinch building, which is the home of the Ether Dome, where anesthesia was first demonstrated on October 16, 1846. And then in the foreground is a bronze statue of a mother and her baby that was erected about 20 years ago. And I think the contrast here helps remind us that, gosh, we've come so far in 172 years, and still, in terms of patient safety, we have so far to go still. So it's obvious to everyone here that we who provide anesthesia care are really vulnerable to medication mishaps. Really, there's no other place in the medical system where a single individual might be in a situation where they're diagnosing a need, they're prescribing a medication, they're preparing the medication, they're administering the medication, they're charting that they gave the medication, then they're monitoring and treating side effects of that medication. Sometimes in a crisis situation, all this happens even in a minute. We just don't have the usual safety nets that are available throughout the other parts of the hospital. So today I was asked to share a story of a medication error that I made, and to touch on the harm that came as a result of that, and really to touch on the recovery too. And I think if anything, it's a reminder to us all that these kinds of medication mishaps can happen to anybody. They can happen to people who wake up in the morning feeling like they're going to bring their best to the care of the patients, and it can happen to people who on the outside look very well trained and competent to us. And I think that it's a reminder that recovery and response and prevention of these kinds of problems is really a team sport. So I want to tell you a story about a patient of mine, Maria, and her unborn girl. Maria came to Mass General to have a primary C-section for her baby who was breech. It had been a totally uneventful pregnancy. The plan was to do the operation under spinal anesthesia. And while the senior resident was doing the spinal quite well, I was busy talking to the patient, reassuring her, measuring her vital signs, entering some information into the electronic medical record, and also connecting up an IV infusion of phenylephrine to her IV. So we routinely use phenylephrine in this setting to offset the expected hypotension that results from the sympathectomy of the spinal anesthetic. This is a way that we can help ensure blood supply and oxygenation of the fetus, and also help the patient feel more comfortable. The mother is less likely to be dizzy and nauseated. As the resident was finishing up the spinal, I happened to look up and I noticed a bag of Pitocin running free flow, unobstructed, into the patient instead of phenylephrine. And I quickly clamped it off and removed that infusion from the patient. So many of you may know that we use Pitocin in this setting after the baby's delivered to help contract the uterus and control bleeding postpartum. But when it's given this way, free flow, to a patient before the baby's out, it causes super physiologic contractions, tetanic contractions, which in effect cut off the blood supply and oxygenation to the baby. So imagine me in the moment. I was thinking so hard and hoping that no harm would come to the patient or to her baby. And also imagine my situation where I was the only one in the room that knew an error had been made. So as I was laying down the patient, I asked the nurse to come over quickly to check the fetal heart rate on the baby. It was my way of making sure that really things were okay. And as I laid the patient down, she looked up at me and said, "When will that pain in my stomach go away?" And then I realized that I had caused a problem. There was tetanic contraction. I had triggered it. The nurse came over. She checked the fetal heart rate and got a heart rate of 60. Many of you may know that normally at term, the fetal heart rate is usually about 110 to 160. So 60 is a sign of fetal distress. But in her mind, everything was going routinely. And so she assumed that the fetal heart rate of 60 was actually the mother's heart rate. And so she proceeded to move the probe around to try to find the true fetal heart rate. But I knew there was a problem. And so I said to the nurse and to the OB intern, the baby's in trouble. That's the baby's heart rate. Get the OB in. We need a stat C-section. Suddenly there was a flurry of activity. The OB intern went to go fetch the OB. The NICU team was called, anticipating delivery of a baby needing resuscitation. The obstetrician came in. She'd been told that, a spinal was placed, and now the anesthesiologist is worried that the baby's in trouble. Again, she didn't really know that an error had been made. How would she? So she came in, she saw the situation, she said, "May, what's the mother's blood pressure right now?" And those of you who take care of patients on the labor floor know that oftentimes, very innocuously, there may be a transient change in the fetal heart rate in response to maternal hypotension. But this was not that situation. I had to physically walk away from the patient, plant myself in front of the OB and say, no, this is a real emergency. The baby's in trouble. I know that I made an error. I gave the patient Pitocin instead of phenylephrine. You have to get the baby out. There was a stat C-section. The baby was delivered. The APGARs were 4 and 8. And I also got help at this point. I was also giving oxygen to the mother and nitroglycerin to help release the tension in the uterus. Afterwards, the mother had iatrogenic uterine atony from the nitroglycerin, and I had to treat her with Methergin. During this time, after the baby had delivered and was crying on the warmer, I looked down at the patient. She was wide awake. She knew that there had been such a rush to get the baby out and there was some kind of emergency. And I said, listen, your baby's okay now. You enjoy your baby. Focus on your baby now. But let's make a promise to each other that we're going to talk about what just happened. Because I made an error. It's hard for me to even say it. I made an error with your medication. And that's why your baby got in trouble and you had this stat C-section. Maria looked up at me. She was a graduate student, actually getting her PhD in education. And she said, wow, sounds like a learning opportunity. Boy, did I luck out, right? So let me tell you more about what happened. Some of you may be familiar with blood gases. This is the blood gases from uterine arteries and uterine veins. Umbilical artery and umbilical veins from newborns. You can see that the baby was acidotic and hypoxic. And just to put this in perspective, pH of less than 7.0 can be associated with ischemic encephalopathy, intraventricular hemorrhage, and cerebral palsy. So the baby turned out to be fine, but I'm sure that if the operation was delayed even a minute more, some real damage could have happened to the baby. So I was lucky. I want to say that about a year later, so I was telling this story at a conference like this, and afterwards a stranger came up to me and said, "Wow, you are so brave. It's amazing to me that in the heat of the moment, you confessed, you told people that you made an error." And I thought about it, and I'd like to think that I'm the kind of person who in the heat of the moment would try to do the right and ethical thing. And I realize that I'm fortunate to work in a place where I feel safe to speak up, to ask for help, and to confess in situations like this without fear of being judged in a bad way or to have my reputation smeared and so forth. So I really feel like I have the benefit of working in a very wonderful safety culture on our OB floor, and that in turn that safety culture affects the care of our patients. So I just want to talk about safety culture in this one slide. I really feel that safety culture is what helps you survive these kinds of instances. It gives you resilience so that you can bounce back, you can adapt, you can grow, you can even come out at the other end stronger than you were before. And when I Googled safety culture, I got 9 million hits. And thankfully, ARC has condensed down definitions for safety culture to these 4 elements that I want you leaders in healthcare to know about. So first, there's the acknowledgement of the high-risk nature of the organization's activities and determination to achieve consistently safe operations. We need a blame-free environment where individuals are able to report errors or near misses without fear of reprimand or punishment. We need encouragement of collaboration across ranks and disciplines to seek solutions to safety problems. And we want organizational commitment of resources to address safety concerns. So consider taking those home to your workplace and making a difference. So as with all events, there was a root cause analysis. I don't need to explain that here, but some of you may be familiar with this new concept of RCA squared, where the second A stands for action. And I think it's really important to take a minute to think about this because it's very aligned with what Mark Warner just charged us to do this week, which is to think about action steps, right? So not just understand maybe what might be contributing to a problem, but what are we going to do about it? And what are actionable, feasible, and sustainable changes that we can make that will make a difference? So in our department, we have our quality and safety work is done by two teams. One is the QA committee that tries to understand the root causes that contributed to an event and lessons learned. And then there's the quality and safety improvement committee, which then takes these lessons learned and tries to translate them, usually in a very interdisciplinary way, into action steps. So what we determined here was that the setup for the error was that the Pitocin infusion and the phenylephrine infusion were together. They had very similar tubing. The phenylephrine was fed through the pump, but separately there was tubing of Pitocin that with the port very close by. So I made the mistake of grabbing the wrong tubing and giving it to the patient. So the first improvement or action that came from this is that we told our residents, please don't hang these drugs all together anymore at the start of the case. You don't need the Pitocin until after delivery, so take the Pitocin and hang it on the wall, and this problem will be fixed. But those of you there are probably some of you in the audience who are thinking, ooh, that sounds kind of like a Band-Aid fix, and it's not really a system, sustainable, important kind of fix. And you may not be surprised to know that actually when we started to look at it, we found out that there were lots of problems related to phenylephrine in our operating rooms. And so just to give you an example, we had an inadvertent bolus of concentrated phenylephrine from a vial instead of ondansetron. They were look-alike drugs next to each other in bins in our med drawer. We had the inadvertent free-flow infusion of phenylephrine without threading the tubing through a pump. And we had inadvertent administration of phenylephrine infusion to a second patient with tubing previously used on another patient. Obviously, all never events. So our quality improvement committee set to work to figure out what could we do more definitively to help these problems so that they never happen again to another patient. And we went to the National Patient Safety hierarchy of actions model to try to figure out what we might do. Many of you know that the actions are categorized as weak, intermediate, or strong. I like to think about them as weak are ones that depend on the caregivers to remember what they're taught or what is written in the policy. Intermediate ones are somewhat dependent on people remembering to do the right thing, but they're given tools and cognitive aids and so forth to help the staff to remember. And finally, the strongest, best interventions do not depend on staff to remember to do the right thing. And this next slide gives you some examples of what these interventions look like. So in our hospital, what we decided to do to address these phenylephrine things are multifold. First of all, we moved the look-alike vials away. So instead of having the phenylephrine vials in next to the ondansetrons, we moved them to a second drawer. This was a temporary fix. Not long afterwards, we partnered with our pharmacy colleagues to create dilute mixtures for infusion bags and also for syringes for bolus administration, so that this task overload of preparing the phenylephrine, spiking the phenylephrine, et cetera, could be eliminated. And finally, we standardized labeling with our codonics machine, many of which you may know also has an auditory function, so it sort of substitutes for the readback function that happens elsewhere in our hospitals. And to just show you what this looks like, we now use our codonics labelers not only for labeling syringes, but also for labeling infusion lines. For example, here, adding a cognitive aid near the port to show that this is phenylephrine. And when we prepare meds and spike them or thread them through a pump, have them ready to go with a clean label. So in conclusion then, I just have two last slides to wrap up. Let's see if I can go back. There we go. So, good things don't happen in a vacuum. I think just as we've all come here today to put our heads together and come up with new innovative ideas and real action steps, the improvements that came after my error were not in solitude, but a result of real collaboration. I have to attribute the transparency that exists in our department about reporting events and really trying to frame them as learning opportunities as opposed to a shame and blame kind of opportunity. I benefited from debriefing with interdisciplinary colleagues. This was an opportunity to figure out what just happened, what needs to happen next, and are we all okay? And in fact, we have a pretty robust peer support program in our department, in large part due to APSF Board of Directors member Maria Van Pelt, who's here today. Thanks to her program, we've come to appreciate that clinicians who are involved with critical events become second victims themselves. They can be bothered with depression, anxiety, recurrent uninvited thoughts. They can have disrupted sleep. And actually taking care of the clinician and perhaps taking them out of their clinical responsibilities helps a potential third victim, that patient who might be cared for next by the clinician who is otherwise distracted, upset, and impaired. And finally, we try not to focus on the mistakes, but we like to celebrate and report on to each other about getting it right and things when they're good. So going back to my patient Maria, I want to just sort of remind everybody that this week, our being together is about bringing our best for the care of our patients. Being brave and inspiring safety and culture change is easier when we frame it around a common good, what's best for our patients. And I'm just really excited that here we are, clinicians, scientists, innovators, inventors, coming together, sharing ideas, and I really look forward to your contributions and learning from you. Thank you.
Wow, thank you very much, May. Terrific story and a great storyteller. Thank you. We're going to move right into session one. And it's how safe are most commonly used anesthetics. And I'm going to have Dave Goodell come up. And Dave is Executive Director of DBG Pharma from Westchester, Pennsylvania, and was one of the real leaders in developing and introducing propofol into clinical practice. So Dave, take it from there.
Thank you. I'm excited about this conference. We're moving into an area in which we're going to look at something that we kind of accept. I've heard anesthesia is a controlled administration of toxins. Well, we need to look at the intrinsic toxicity of each of the agents that we're using, and I think it will improve how we can, who is the best person to administer this. So before our break, and we're going to take a break right on time, we have three presentations. Our first one is Dolores Njoku, and she is an expert in sevoflurane, desflurane, hepatotoxicity. Dolores?
Okay, I think I know how to move this next. Okay, all right. First, I want to thank you for inviting me. Guys, it's not every day that I get to talk to a bunch of anesthesiologists and pharmacists and nurses, and for me, this is the ideal talk. So I promise not to keep it too sciencey, and I want to bring you up to date to what we actually have done as anesthesiologists. So we're going to focus on sevoflurane and desflurane toxicity. I have a couple of disclosures that I have to talk about. The first one is online podcast for pediatric anesthesiology, so it has nothing to do with this. But the second one does, where we actually, as anesthesiologists, identified the immunogenic portion of the enzyme responsible for metabolizing the drugs that we used, and we got a patent for that. All right, so at the completion of this lecture, what are we going to learn? Well, we're going to talk about comprehending the prevalence of hepatotoxicity associated with sevoflurane and even desflurane. We're going to review accepted mechanisms of hepatotoxicity so that we can come up to date with what we're doing now, because a lot of this has been moved to the realm of the hepatologist, and my ideal world will move it back to anesthesiology, even if it's through APSF. And lastly, recognize the gaps in knowledge, and I'm going to start with the gaps that I think are there, but I'm really hoping that you guys will tell me really what the gaps are, because mine will have a basic science bent. So what's the background? What was out there? Why do I study this? Well, liver disease and cirrhosis are the 6th most common cause of death in adults between the ages of 25 and 64. Most people believe that liver-related mortality in the United States is actually underestimated. Drug-induced hepatitis is a leading cause of liver failure and is the most common reason that a drug is removed from the commercial market. Many types of drugs induce immune-mediated toxicity, and sevoflurane and desflurane are included in that group. Most of the anesthetics we know have been associated with liver hepatotoxicity, and that includes sevoflurane and desflurane. Sevoflurane and desflurane were induced because they had decreased metabolism, because we believed at the time that metabolism of the anesthetic was the root cause of the hepatotoxicity. We now know that there are other causes, but metabolism does have a role. So the background summary, to bring us all to where we are now: liver-related mortality is at an all-time high. The burden of disease associated with the liver may be underestimated. Immune-mediated hepatitis is a final common pathway, which is why I studied it, even if it's from anesthetics. And desflurane and sevoflurane have been associated with hepatotoxicity. So then what is the incidence or prevalence? And in this way, I use them in the same way. I know they're different. However, we don't know incidence or prevalence for most of it, so at this point, we should look for both. Well, we know that desflurane was introduced around 1993. The prevalence that I found in the literature was recorded at 1 in 10 million. And this was done by epidemiologic studies and pharmacogenetics, and these authors at least tried to figure out what would be really the prevalence of desflurane hepatotoxicity. When I searched in the literature for desflurane hepatotoxicity reports, I could find 5 cases where I had all the information that we as anesthesiologists would need to evaluate the case. So let's go through them. So basically, I put the things that we look at. We look at age, we look at what procedure they had, we look at prior anesthetics, we look at post-operative day onset, also whether or not they had elevated liver function tests, incidence, or did they do an infectious rule-out to rule out that there were other infectious causes of the hepatitis. Did they look for antibodies, like for cytochrome P452E1 or for the trifluoroacetyl metabolite? And then what was the outcome? So if you look at the age, it was variable. Most of them were adults, but it was even reported in a child. If you looked at the procedures, variable. All of these had a history of prior exposure. The postoperative day onset could be day 1 or even day 14, so up to 2 weeks later. And by that time, you can rest assured an anesthesiologist did not see them. They all had elevated LFTs. Most of them ruled out infectious causes. Some of them tested for autoantibodies. And the good news is the outcome of survival was there. Let's look at sevoflurane. That was introduced in 1999. The incidence or prevalence of hepatotoxicity is unknown and unquoted anywhere, but most people assume that it's less common than desflurane hepatotoxicity. When I searched the literature, I could find 9 cases that could give us at least some data to look at, and I brought them here today. If you look at the same parameters that we look at desflurane hepatotoxicity, we see that the ages are mostly adults, but the earliest case was actually in an infant. It was in 1991, and I know I said that it was introduced in 1999, but that was introduced in the United States. By 1999, it had been used for years in China. The procedures were all over the place. The prior exposure, the interesting thing for sevoflurane, you didn't always have to see an anesthetic that was halogenated before to develop hepatotoxicity after sevoflurane. The post-op day onset was even more variable than desflurane, and the later cases were actually cases referred by hepatologists. The elevated LFTs were there in all of them. The infectious rule-out was missed in many, and in some they found, or in one they found, Epstein-Barr virus was also present. Many of them did not test for the known autoantibodies, but the big difference between sevoflurane and desflurane hepatotoxicity is that many of them died. So in summary, desflurane hepatotoxicity has been reported at least 5 times. 80% of the cases were females. 20% of the cases were males. All of the reported cases survived. In contrast, sevoflurane hepatotoxicity has been reported at least 9 times. 55% of the cases were females. 33 of the cases were males. In 11%, we did not know the sex of the patient. Death occurred in 44% of the patients, and of the patients that died, all were female. So if metabolism is the key, then why did it occur? Are there susceptible persons or conditions that increase susceptibility to desflurane or sevoflurane hepatotoxicity? So what are the accepted mechanisms? We all know here, these are smart people. Let's talk about them for a minute, because it's in all our textbooks. We know that females have an increased susceptibility to hepatotoxicity from anesthetics. We know that the person may present with a rash or itching or something that looks like a drug allergy. They may have eosinophilia. They may have serum autoantibodies to cytochrome P452E1 and to serum anti-drug metabolite antibodies, what was known as TFA. They may have inflammation or failure of their liver, mild or moderate increases in liver enzymes, and a family history of autoimmune disease. But we also now know this. And I promise not to be too sciencey, but I have to be a little bit sciencey to get us where we need to be. We know that if we took labeled liver proteins in a mouse and labeled it with our metabolite and induced a sort of viral type space, we would develop antigen-specific T cells. And these antigen-specific T cells travel to the liver, and in the liver they recruit neutrophils and eosinophils, and they activate mast cells either directly or through cytokine expression. These cytokines also go on to increase or to produce antigen-specific B cells, and these B cells produce the autoantibodies and the antibodies that we know and we are familiar with. We know this because when we did this, we could induce this in a mouse. So we as anesthesiologists have induced the only model that's translational for anesthetic hepatitis that actually works for immune-mediated hepatitis. And if we use the viral mimic, just a little bit of inflammation. If we use just the liver proteins, almost no inflammation. But if we combine the two, we develop the inflammation similar to what we see in our patients. So now we can start talking about what the initiators could be and explain some of the things that we've seen for years. We also know this. Cytochrome P452E1 has an immunogenic portion, and that autoantibody that you see has issues. The autoantibody does things like block the entrance to the enzyme, meaning that if you had that and you tried to take something like acetaminophen, you would develop toxic metabolites and your liver would fail. If you had this and you tried to develop anything that was associated with CYP2E1, had a drink, had a glass of wine, you would develop hepatotoxicity. So it doesn't come alone. We know that patients who have anesthetic hepatitis with the complete rule out, not the ones you saw in the case report, these are the ones that come directly to our lab. We know that those patients have increased levels of antibodies to that one immunogenic piece. So we know that we can look for that. All of them don't, but most of them do. So then to summarize, immune-mediated hepatotoxicity, this time from desflurane and sevoflurane. In this way, chemicals, antigens, or drug metabolites activate the immune system. Yes, there might be some stress responses or some viruses that are associated with it. And these induce cytokines, chemokines, or other tissue factors that then cause end organ inflammation and immune dysregulation. So it not just causes the hit, it causes the immune system to act up and propagate the hit. So then the question is, can we then deal with this regulatory problem? If we could accept the hit and accept or not accept the immune regulation, could that help us? And I bring this up because there are regulatory T cells that we talk about all the time in the science world, and we're going to focus on that today just for a minute, but there are also other regulatory cells, so the field is really wide open. We know that some of the cytokines, like IL-33, induce regulatory T cells, and this upregulation of regulatory T cell can reduce hepatitis. So where does that put us with anesthetic hepatotoxicity? Well, we know that anesthetic hepatitis patients have elevated levels of IL-33. So what that means to us is that the body is trying to protect itself. No body takes any insult without trying to protect itself. However, in anesthetic hepatotoxicity, what we find is that IPEX, or the human corollary of FOXP3 or regulatory T cells, is actually diminished. So we have immune dysregulation that propagates the disease. You can see it here even better where we put control patients. When we look at IPEX and IL-33 levels, it just goes right up the curve where it's supposed to go. But when we take anesthetic hepatitis patients, it doesn't. Your IL-33 is dysregulated from your regulatory T cell. So what does all of this mean? Well, it means that deficiency of regulatory T cells can increase hepatotoxicity, and we know that it increases disease severity in females. So with all this, I promise to be brief on the sciencey part, but keep it clinical. What are the gaps in knowledge? Where do we see it from at least the lab translational point of view? And I'm bringing it to you from this quality and safety point of view. What are the gaps in knowledge? Well, in our mind, we can say, what is the incidence or prevalence of perioperative liver failure? We have no idea. If you Google it, do any search you want, you can't find it. I've tried. What is the incidence or prevalence of sevoflurane toxicity? Are we content to say that it's less than Deslorane? Maybe more reported? I don't know. Is sevoflurane hepatotoxicity really more severe in female patients, or are female patients really just more reported? And then could regulatory cell markers be developed as checkpoints for sevoflurane or Deslorane hepatotoxicity? Well, our friends down under, I know somebody mentioned New Zealand, these are my friends from Australia, and particularly one in particular, Amanda Nicol. She's a hepatologist that I've worked with for years, and they're trying to get at this question, like what is, the incidence of abnormal liver function tests coincident with anesthetic hepatitis. And the way they determined it was anesthetic hepatitis was by using a likelihood score of a drug being associated, or the RUCAM score. And in their population, they found a pretty high concentration of 3% of their trauma patients were having hepatitis that they thought was due to anesthetics. Now, I'm not sure I agreed with all of it, but I do agree with the fact that we should figure out what it is. Well, no one sits at this podium alone, and these are the people that have helped us. The mouse model was really by a bunch of really great grad students, and the epitope by some undergrads and postdocs, regulatory T cells as well, and also some regulatory B cells. Some of you guys out there know me as your postdoc, and I wouldn't have gotten here by myself. You know who you are. I won't totally embarrass you because it's a well-known phenomenon. All right, that's all I got.
Dave, just before you introduce our next speaker, Kurt, if you have 1 minute. We've got some folks outside who haven't been able to find seats. If you have a seat available beside you, could you raise your hand? It's a shame to have them come all the way to Phoenix and not be able to get a seat in the room. So we've got some up here. Sarah, anybody else out there we need? You'll bring a few more people in, will you? Okay, let's get them all in the door. So, gee, I hate to have them, not that it's bad to stand outside in Phoenix, but versus Minnesota, for example. We'll just make sure everybody gets a seat. Okay. I got it, Sarah? We're all set? Okay. Thanks a lot, Dave.
Thank you, Dolores. That was fascinating. And what I think I would like to say, if you read the sevoflurane label that FDA puts out, it almost says that this hepatotoxicity doesn't exist with sevoflurane. So let's move on to the next one. This is nitrous oxide, and Kirk Hogan is going to tell us about vitamin B12 destruction and myeloneuropathy. Welcome, Kirk.
Who's got the clicker? Oh, is it this one? Okay. So I'm here under a little bit of deceptive pretense, and that is the title of the session is How Safe Are Most Commonly Used Anesthetics? And I think nitrous oxide is falling into an uncommonly used anesthetic at my institution and a lot of other places around the world. So when I've given this talk before, I've had people come up to me and tell me it's a Coles to Newcastle talk. We gave up a long time ago. The operative word here is our, and that is, as anesthesiology seems to be throwing this drug as far away from itself as it can, it's being picked up by a lot of other people. Labor and delivery, pain and psychiatry, of course, dental, and emergency rooms. The latest thing in our part of the woods is ambulances are being equipped with nitrous oxide to give to people on the way to the hospital. You can imagine if people have sucking chest wounds and all kinds of other things, apart from anything I'm going to talk about here, what sort of disasters and catastrophes we're looking at. So thanks to Dave and Mark for asking me to come and talk. On this specific topic of nitrous oxide toxicity, it's by far not the only problem with nitrous oxide, but it's the one I've been involved with for 40-odd years now, and I just give you the quick high-altitude overview. So, as many of you know, nitrous oxide was first recognized for analgesic properties in 1810 when Humphrey Davy kicked an Ottoman and it didn't hurt, and he suggested we use it for anesthesia. It wasn't actually used for anesthesia until the 1840s with some sometimes catastrophic demonstrations, but slowly it grew in recognition. And then into the 20th century, and certainly when my father and I started practicing, both 20 years apart, nitrous oxide was a given in balanced anesthetic techniques, and that is we were able to use nitrous oxide at 70% to get away with using less ether and halothane, which had all kinds of other bad properties. So in the 70s and 80s, I taught my residents, and into the 90s even, that nitrous oxide was inert. It had no relevant or important or pertinent physiologic toxicities that we needed to worry about. It was mother's milk. It was a fantastic drug. Nitrous oxide, interestingly, was a grandfather drug when the FDA was created, the Food, Drug, and Cosmetic Act in 1938. And it was identified as one of, I think, 4 or 5 medical gases, oxygen, nitrogen, carbon dioxide, helium, and nitrous oxide, as being exempt from the requirements of that long statutory number that only lawyers could love. And if you turn to that, what you find out is it was exempt from package inserts that are required to show adequate information about relevant hazards, contraindications, side effects, and precaution, under which practitioners licensed by law to administer the drug can use the drug safely and for the purposes for which it was intended. This is the FDA's job. I won't ask here, but I do ask in other places, how many of you have read the package insert for nitrous oxide? And the answer is none of you have, because there isn't one. The FDA has never investigated or established the safety of nitrous oxide. It hasn't even tried. Ask your colleagues and patients if they know this, and I think you'll get the same blank look that I get. Into the 1940s, we first got our indication that maybe this wasn't going to be such a sanguine story. In Denmark, after World War II, there was a terrible tetanus epidemic. And to treat the pain of tetanus, people were given nitrous oxide, and one patient survived, but almost all the others died, and the one that survived was a narrow miss because of disastrous, catastrophic bone marrow toxicity in every single one of them. This was known in the hematology literature, but it didn't creep into our literature for quite a long time. And the only reason I heard about it is Bob Schilling was one of my mentors of the Schilling test for B12 and pernicious anemia, which us older guys would remember. Into the 1970s, when I was in medical school, and others who were in medical school then remember, we first started hearing about subacute combined degeneration, where dentists would go into the office and strap themselves into a chair and put a mask on, and doing that 6 or 7 times, and the next thing you know, they had foot drop and classic vitamin B12 deficiency myeloneuropathy in the spinal cord. And I remember actually having a dentist come and talk to us as medical students and describe the symptoms and tell us, be on the lookout for this. It wasn't until the 1990s that the first case reports started appearing about acute combined degeneration of the spinal cord. And that is with clinical use and clinical durations and clinical concentrations, a single use only, people started developing severe, disastrous myeloneuropathy. This literature is independent of our anesthesiology literature. It's in the radiology literature and the neurology literature and so on. And one of my side hobbies is collecting these case reports. I'm now up to 20 with about 25 patients. And if you find any, send them to me. And if you write me, I'll be happy to send you the bibliography of these cases. They are completely outside our anesthesiology literature for reasons I'm not aware of, but they're really harrowing. In the 1990s, NIOSH and OSHA got involved in regulating the parts per million that we can have in our OR with scavenging this drug, and it's 8 parts per million. But the FDA and the DEA don't regulate nitrous oxide at 700,000 or 800,000 parts per million. I can't think of another drug or compound, really, that has this sort of weird disparity in federal regulation. The first identification I'm aware of nitrous oxide toxicity in an acquired disorder was a little kid who had cobalamin deficiency because of a weird diet his mom was taking, and he was being breastfed, got nitrous oxide for a single anesthetic, and developed megaloblastic anemia and neurologic changes. The first genetic predisposition was the workup we reported of a kid who died at our hospital in 1984. It took us 20 years to figure out why he had mutations in the single carbon pathways that nitrous oxide poisons. So only in the last 20 years have we been aware of the specific susceptibilities that people can have to this drug and its toxicities. Nitrous oxide is the only inhaled anesthetic that will kill everyone who breathes it. That means its safety resides only in individual susceptibility, the duration and frequency of use, the cellular reserves of methionine that we have when we come to the operating room. This is why everybody doesn't get sick with nitrous oxide, because most of us have cells full of methionine. And how much damage is acceptable. I could also phrase that by saying how much damage is detectable. How hard have you looked for damage? So the problem here is this cycle. This beautiful cycle was evolved on Earth 2.5 billion years ago. Carbon-based life forms in all the cells of our body need methyls to make everything, neurotransmitters, myelin, everything else you can think of, and this is the only place they can get it. B12 lives in that enzyme MTR, methionine synthase is its long name, and nitrous oxide yanks an electron off the B12, makes it cobalt-3, and it can no longer work. You turn the nitrous oxide off, it doesn't restore itself, it has to be resynthesized for 4 or 5 days. As well, there's pathways that have mutations. MTHFR is methylene tetrahydrofolate reductase, which I can say pretty well now after 10 years, but my tongue stumbled on that for years. And the indicator that you're running into problems is accumulation of homocysteine. Homocysteine is a procoagulant. It inhibits smooth muscle relaxation. It sets people up for clots after surgery, DVT, and myocardial ischemia. But the bigger fear is methionine deficiency in kids who have genetic and acquired predispositions of this cycle coming into the operating room. Important points. Nitrous oxide inhibits methionine synthase in everyone. This isn't idiosyncratic inhibition. Every single one of us will get homocysteine elevation to some degree after exposure to nitrous oxide. What's idiosyncratic is your susceptibilities to the consequences of that. The only cells that we know the mean half-time of inactivation are hepatocytes in culture. Nobody's been able to or had an interest in studying other tissues. Recovery, I mentioned before, takes 4 days to resynthesize, not when you DC the drug. Serial exposure is used by people who want to study this single carbon pathway cycle using nitrous oxide to see how they can mess it up. Human, fetal, neonatal, and geriatric kinetics of inactivation and reactivation are unknown in any tissue. This is a huge knowledge gap. Nitric oxide inhibition of methionine synthase is rapid, potent, irreversible in all patients, and harmful in a substantial proportion of patients that are not identified before exposure. The deleterious consequences are long-lasting, unlike the labor and delivery, midwife, obstetrics literature that's starting to grow that says the effects of nitrous oxide are evanescent and short-acting. And nitrous oxide toxicity is distinct from nitrous oxide mechanisms of action, which is not to say this is the only toxicity of nitrous oxide, but this is the one I'm talking about here. So the enzyme methionine tetrahydrofolate reductase, we found a couple mutations in our little guy who died from this disorder, but what was really surprising to us is how common mutations are in this disorder. I have 2 of them on 2 different chromosomes. 20% of us in this room have at least 1 and likely to have 2 different mutations in this gene that is a precursor to methionine synthase. So 20% of us have a genetic predisposition to elevated homocysteine deficient methionine after nitrous oxide exposure. This changes based on the geographic origin of your ancestors. Interestingly, there's nobody who's a compound homozygote for mutations at both these sites in this gene because it's an in utero lethal combination. You can't make single carbon transfers. Additional polymorphisms are these cycles spin out directly and indirectly into other things. They're coded for by genes that have polymorphisms, and we're just beginning to tease all that out. So less well known than that, and surprising to me as well, is the incidence of B vitamin deficiency in the people that come to our OR. People who are 65 to 75 and older have about a 10 to 20% incidence of B12 deficiency. They also have a 10 to 20% deficiency in folate and pyridoxine as well. Why we put people to sleep who are vitamin deficient is a mystery I can't explain. When you regenerate tissue after surgery, you need these things to make good tissue, and we just blithely go ahead and do this. So I think this is a huge opportunity for improving our care right now. Even more weirdly is the incidence of B12 deficiency in 3rd trimester. Kids can have perfectly, and their moms, not their kids, can have perfectly high levels of B12 in the 1st and 2nd trimester. In North America and Europe, there's about a 20% incidence of B12 deficiency in the 3rd trimester that persists until about the age of 10. This is in countries that are getting fortified milk and cereal and rich diets and so on. It's far worse in other parts of the world. If you add this, a 20% deficiency, the genetic susceptibility, a 20% deficiency in acquired disorders, that means 5% of patients coming to us that get nitrous oxide are setups for problems. What should a prospective study look like now in view of this knowledge? In other words, if we want to study, which we should, especially advocates of continued use of nitrous oxide, what sort of data should be demanded of them? And that is, we should have B vitamins before and after exposure. We should have single carbon pathway substrate and product levels. Homocysteine and methionine can be easily measured. We need to know this before and after nitrous oxide exposure. The genotypes, and now what I'm particularly interested in is the epigenotypes, that is methylation of other genes that are involved in gene switching and integrated circuits of the genome, need to be studied, evaluated, and compared in people who get nitrous and don't. Enzyme activities in target tissues are easy to get now, although not cheap. Checking someone before surgery for megaloblastic indices on red blood cell seems to me a no-brainer, but lots of times now we're not doing H&Hs before surgery, but it's surprising how often I would spot people who had mild anemia and big megaloblastic changes who would be bad candidates for nitrous oxide. Cellular indices of genotoxicity is a bird's nest on the ground study. We need to get cord blood, and we need to look at people who've gotten nitrous oxide and see if they have sister chromatid exchanges or comet assays to show that this stuff is a genotoxin. And most important, above all, is the clinical studies. People who advocate nitrous oxide use need to come forward with well-designed, well-conducted, well-interpreted, and analyzed studies about long-term clinical outcomes with nitrous oxide exposure before we can continue to blithely use it. And the last thing I'll mention in this regard is we're really lucky in that we have a positive control that doesn't have any toxicity to single carbon pathways, and that's xenon. So you can imagine beautiful studies that could be done if there was the will to do them. The Magna Carta of anesthesiology and in fact of medicine is informed consent. And my way of thinking, we really need to get behind this in a bigger way, and a lot of the things we're talking about here at this meeting. Nitrous oxide has no established benefits that I can find or anybody can advocate in anesthetic maintenance now. A little bit of use at the beginning of the endo case in peds to smooth induction and emergence. There's no evidence that that's going to be toxic. Certainly nitrous oxide in malignant hyperthermia is an ace in the hole. But otherwise, we don't need it for anything. Compared to a couple tenths of % of sevoflurane that you're giving it anyway, what does it add? But nitrous oxide use is literally exploding outside the OR. If you were able to read all the labor and delivery articles that I've been pouring through the last 6 months, you'd be shocked at the inaccuracies and outright lies that are being told about this drug. as people who are picking it up and giving it to mothers who are laboring for 14 and 20 hours. I would pay $500,000 not to have my child or grandchild born breathing this stuff for the reasons I've outlined. If you want to use it, then get the B vitamin levels and genetic tests and supplement people to make sure that their risk levels are the minimum. Patients are not tested for susceptibility now, and patients and families are never informed of the risks of nitrous oxide. I have an article coming out in the Journal of Law and Medicine that's 75 pages in dense legalese if you're interested, about anesthesia and informed consent. If you ping my email, I'll be happy to send that to you. It's about postoperative cognitive dysfunction, but in fact it's about every phenotype that we deal with as anesthesiologists. So not to be too dramatic, it's perfectly factual to say that nitrous oxide is a bone marrow gas and it's also a nerve gas. The effects of nitrous oxide on the regeneration of tissues after surgical or traumatic injury has never been studied. We now have a submission going into anesthesiology next week. It's a shocking gap in our practice that no anesthetic, inhaled or intravenous, has ever been studied for its effects on regeneration of tissue after surgery. Ask your residents, ask your fellow staff what the data is on this. You will be surprised that there is none. So here's another big gap. So questions. If newly introduced and developed, could nitrous oxide get FDA approval? You know what I would say. Would a pharma executive wish to apply for FDA approval in view of minimal risks and view of assured risks and minimal benefits? I can't see it. It would be a terrible business model. Would academic investigators wish to conduct appropriate prospective trials like I've devised? No, it doesn't have enough benefits. I wouldn't do these studies that I just laid out for you. Most important, would patients and parents of children wish to provide fully informed consent? In other words, in the research consent, it would say, this is not an FDA-approved drug. The FDA has never looked at it for safety and efficacy that are needed to participate in randomized trials if we were antecedent to an FDA application. So that's the end of my talk, and that's the Hindenburg. And, well, the reason he's there is I got pummeled with questions for years about how much nitrous oxide did you use, Hogan? And finally I sat down and decided to calculate, and I did nitrous opioid anesthesia for neuromonitoring for decades, and long cases at 70%. I pumped in tons of nitrous oxide and taught hundreds of residents what a beautiful drug it is. And when I calculated how much, 2 dirigibles of this stuff came from these hands. So I'm a reformed nitrous oxide abuser, and I admit that.
Wow, great talk. APSF's motto is do no harm. Do we sit on the sideline and let hospitals, there's a hospital in Westchester that is promoting its use of nitrous oxide for labor and delivery. Do you believe that in this day and age with our knowledge base, that we stand by the sidelines and watch this? Every emergency vehicle you see could be giving nitrous oxide to patients, ruining their chances for recovery. Okay. Moving on. I love the topic of sulphite toxicities. They are involved in morphine, they're involved in propofol. I published a poster at the International Anesthetic Pharmacology meeting showing that curare and morphine do not release histamine. They're not histamine releasers. Sulfites were. Those studies all compared a sulfited morphine to a non-sulfited fentanyl, a sulfited curare to a non-sulfited vecuronium. There are 4 people in my choir, and I don't sing in a big choir, that are sulfite sensitive. I think this is a huge problem, kind of the iceberg beneath the sea type of thing. So we have the world's experts on sulfites. Max Baker, my friend, he has even gone to the FDA with me to talk about this subject to the FDA people there. So, Max, you're up.
Okay. Well, Dave, thanks for inviting me. Sulfite is not one of these topics that you set out to become an expert on, but I did have a friend, David Goodell, that said, would you look at this? And I'm harking back to looking at sulfites in propofol emulsions. And so I picked up some information along the way. I'll share some of this with you. So generally, sulfites have been around for a long time, and so it kind of falls into the category as well. It's in a lot of your drugs. Is it toxic? It's obviously not overly toxic, but could there be low-grade problems with it? And staying true to my title, sulfites are equivalent to sulfur dioxide, SO2, and we're exposed to quite a bit of that, particularly if you've recently been over in the Big Island, Kilauea. These volcanoes are putting out lots of sulfur dioxide, which is the equivalent of sulfite. It's also combustion of fossil fuels, air pollutant. Those are inadvertent exposures. We make some ourselves. So as our sulfur-containing amino acids break down, we generate some sulfite in our body. So it's quite prevalent. So deliberate exposures are as preservatives. These, you will notice in wine, we probably consumed a lot of sulfite last night, some of us. This really goes back to Roman times when they actually burned sulfur candles and found that kept their wine and beers a lot longer. It's been on fruits and vegetables, been placed on those to prevent browning, so you bring out lettuce in a restaurant, it stays green for a longer time. And then, of course, in pharmaceuticals, which is sort of our focus here. Well, the FDA has designated sulfites as GRAS, meaning generally regarded as safe. And so the premise is that they're safe. You can put them in any formulations you want, any foods, unless a problem occurs. Then it has to be dealt with. The other thing is that they have to be on the label. So it's kind of hard to see on the label. Bottle of wine on the right, you can say it contains sulfites. And then in the cold relief, you'll also see that it contains sulfites. So by law, it has to be in the label. So what does sulfite do? It's a unique excipient because it's a reductant. That means it can contribute electrons to some substrate. It's an antioxidant, similar, not quite the same, and it's antimicrobial. So it does those three things, and that's why it's so good for drug formulations. But there are problems with it, and I'll note that I got references. I have a reference list at the end, so if you'll see the notation for reference, I'll provide this to the whole group later. So pharmaceuticals, and so the question is, what are sulfites? Because if you read the label, you might see bisulfite, sulfite, and then you might see metabisulfite. So, it's kind of confusing, but it all comes back to the molecule SO2. And chemically speaking, it's oxidation state of 4, which just means that the sulfur's sharing 4 electrons. And you'll also notice, if you look at the boiling point, it's a gas. So minus 10 degrees, it will exist in the gas phase. So it doesn't necessarily stay in the aqueous phase. It can also be, you can be exposed in the gas phase. So I apologize for the chemistry here, but it helps you understand it a little bit. And that sulfur dioxide, transitions easily between the gas and the water phase. So it's as you know, carbon dioxide for sure, it's a lot like carbon dioxide. So combined with water, forms sulfuric acid, which doesn't stay as sulfuric acid, dissociates, forms disulfite, just like carbonic acid does, then loses another proton, then it's bisulfite. And then if it loses another proton, then it's sulfite. So these are all equivalent. the molecules are changing back and forth and depending on the pH. So acidic pH, you'll drive off SO2 just like you would drive off carbon dioxide. So you will see in different formulations bisulfite or sulfite, but there's one more, and that's metabisulfite. So what's metabisulfite is just a molecule of SO2 condensed with bisulfite, and then you get metabisulfite. So functionally, they're equivalently the same. They can reduce and participate in clinical reactions because the metabisulfite will, in solution, will release bisulfite and then sulfite, sulfur dioxide. So you will, if you read the label, you'll probably see sodium, sulfite, bisulfite, metabisulfite, or potassium. So those are the common forms. So typically, sometimes it's just labeled as sulfites to make a shortcut. So functionally, they're very equivalent. So endogenous to us, so sulfites are toxic. We know that. We generate sulfites in our body, and some people are born with a sulfite oxidase deficiency. And so in that case, then this is a 2-electron oxidation, and it goes from sulfite to sulfate, which is non-toxic. So this happens in our body constantly, and the sulfite oxidase can be viewed as a protective enzyme. So what are the toxicities that we know about? So these would be neurological abnormalities from the sulfite oxidase deficiency. And then also, as we well know, there are allergic reactions to sulfite. So these, the symptoms are those that you know. And the FDA indicates that the sulfite deficiency and sulfite allergies are probably low, and that are more common in people that already have asthma. So, it's a case where we do have 2 known toxicities. We don't know if they arise from drugs per se, because basically nobody has really looked at them very hard. So what I have to need to show you then is that sulfite does 2 things. It's protective because it donates electrons. It's an antioxidant. When the balance of sulfite to oxygen is just right, it can form a free radical. Now, a free radical, then, we know, is a reactive species. It's got to bind with something, and it's got to do something to satisfy the radical situation. So the sulfite in the presence of oxygen can form the radical. So this is an auto-oxidation process. It can occur in the presence of just atmospheric oxygen. Kind of slow, but it does occur. And there's also an enzyme in the body, myeloperoxidase, that will also do it. So the key point here is that we can detect it. We can detect it by electron paramagnetic resonance, or ESR. And so this is some of the stuff that we did before. We were looking at sulfite reactions in emulsions, and we also looked at sulfite reactions in morphine. So to make a long story short, this is a label. This is a propofol. I believe it had 0.25 milligrams of sulfite in it. We took it right out of the vial. We mixed in the radical trap and put it in the detector in just about that amount of time, just within a minute or so. You can see on the left, you get a very strong signal for the free radical. Another formulation that did not have sulfite in it, another propofol formulation, flatline. So you are, in essence, with that formulation at least, injecting free radicals. So we also wanted to look at something else. So we looked at morphine, and so we got a generic morphine with bisulfite. We did the trapping, and we saw the same thing. So it was that quick. So we used a trap called DMPO, put it in the electron resonance machine, and then saw it immediately. Also, this is actually reported back in 1971 that morphine will adduct with sulfite. And again, this is when it's exposed to air, and in this case, it formed morphine sulfonates. So most people don't realize that. Now, these are not fast reactions, they're slow reactions, but they do occur. So the other thing we did is try to unravel what happens in the propofol emulsion during this process. And we found that in addition to sulfite, the lipids are peroxidized, and the peroxidized lipids accelerate a reaction that causes two propofol molecules to bind together. And so we call these dimers. And so what we did, we mimicked an infusion over several hours, and within several hours, we generated a propofol dimer, and we also generated the propofol dimer quinone, which imparted a yellow color. So if you ever see a yellow color with your propofol, you know you have propofol quinone. So anyway, so this shows that actually the sulfite can react with the drug substance, the formulation components, and we also show that you could actually infuse free radicals, which have to be quenched somewhere in the body. So we did a little searching of the compounds or the drug formulations that have sulfite, and so you can see here that a number of them do. The concentrations vary significantly, and these are basically due to what the manufacturer considers an appropriate amount of preservative action, whatever it might be. So propofol here on the left, actually on the right, actually has a smaller amount than these most other formulations. So in the case of edrophonium, it also has phenol added as an additional excipient. So there's not a lot of focus on what sulfites do in biological systems. There's a few papers that keep dripping out over the years. These are some recent ones. And the top one is it found that sulfite induces protein oxidative damage in granulocytes. And they found that that's dependent on this enzyme called myeloperoxidase. And then they actually did the same thing, used EPR, and found the creation of free radicals. So the next two, what effect does protein sulfite have on neurological activity? Again, this is in vitro, not a whole animal. They found that it stimulated voltage-gated sodium currents. And these were affected by, in this case, SMB is sodium metabisulfite. The last one is whole animals. Pilocarpine, as you know, is a strong convulsant. And then dosing the animals with sulfite actually exacerbated the seizures. So this evidence is pointing there might be some neurological effects of sulfite. And so to wrap it up real quick, this is my recommendation, is use sulfites as a second choice. I guess as a group you'll decide. And the wind is sort of at your back here because more drugs are being manufactured without sulfite. And so you'll see parabens, phenol, benzyl alcohol, benzolates, and also in a lot of formulations they're just taking the preservatives out and they're preservative free. So these are more common in the single-use formulations. So there's a lot of questions about sulfite. Is it a concern? Is it toxic? It certainly has the chemical potential to be. So that's it.
Another great talk. Okay, we're to our break. So I have like 15 minutes. So 20 after I will begin my talk precisely at 9:20. So be back here because I'm going to fly through my stuff.